Good evening, everyone. My name is Brooks Kuhn. I'm an assistant professor at UC Davis and co-director of our comprehensive COPD clinic. Today it's my honor to present on behalf of the California Thoracic Society strategies to break the cycle of COPD exacerbations. As we spoke before, I want to thank Electromed for sponsoring this talk, but the opinions and slides in this presentation are all my own. So the goal of today, we're going to talk about what is a COPD exacerbation and really why does it matter so much. I'll kind of pitch my approach to evaluating both chronic COPD patients and those in exacerbation who suffer frequent exacerbations. And really, it all starts with just doing a detailed phenotyping of the patient. And then really from there, it's about personalizing care and figuring out exactly the interventions that help people, and often taking patients off medications that we think may actually cause harm. So to get us all on the same page here, the gold definition, or global obstructive lung disease definition of acute COPD exacerbation is an acute worsening of symptoms requiring escalation and treatment. Now, this is the rub, and this is the asterisk around a lot of the data on here, is that it's defined by how we treat it. So it's an acute worsening, and the challenge is, as this picture shows in the bottom left of the screen, most COPD patients, they have good days, bad days. It's up and down. So one of the challenges they often deal with, and we deal with the clinicians taking care of them, is delineating what is just a couple of bad days in a row and what is really constituting an exacerbation. As such, a lot of the data that's most compelling and most focused upon is really focusing on severe COPD exacerbations. Moderate exacerbations are defined as those treated with corticosteroids and antibiotics as an outpatient, whereas ER visits and hospitalizations constitute severe COPD exacerbations. If you look at the epidemiology of these severe exacerbations, they actually occur quite commonly. The data on the slide here demonstrates that upwards of a quarter of patients in the United States deal with severe COPD exacerbations in the last year, just as defined as being in the ER, and 17% of those ended up being admitted in the past year. In data from 2006, that's upwards of 1.2 million hospitalizations per year, and I think we all know and feel that from our own clinical practices. There's an incredible cost associated with this, where it's talking more in the percent of GDP than just simply millions and billions of dollars. Unfortunately, contrary to trends in other diseases, between 2001 and 2012, unfortunately, we haven't seen a big change in the number of discharge, ER visits, and 30-day readmission rates. And a lot of that has been the impetus for CMS and other governing bodies to kind of get involved with COPD and trying to put money behind incentivizing us to do better with admissions and readmissions. Again, I think one of the big issues we have is that COPD exacerbations beget COPD exacerbations, and upwards of 15 to 25% of the patients admitted to the hospital end up having a readmission in a short period subsequently. As I mentioned before, exacerbations beget exacerbations. It's a little complicated slide, but the y-axis here shows the rate of the next severe exacerbation per 100,000 days. With both severe exacerbation and severe exacerbation plus death, with the x-axis demonstrating time after the first exacerbation. So the authors of this paper demonstrated, they're trying to pitch that typically patients have after their first exacerbation, there is a little sweet spot, a little time period where intervention is potential. Subsequently, the second, third, fourth, fifth, you see the distance between these peaks gets quite narrow, suggesting that exacerbation begets more rapid exacerbation. And this is really that cycle referenced in the title of when you just can't break them. They get in and out of the hospital. And often, the die is cast to some degree once they get in there. Interventions tend to be less effective. So what's the big deal? What's the focus on exacerbations? It's because they have a big effect on the overall outcome of patients who suffer from COPD. There's a persistently negative impact, worsening quality of life, worsening functional status, increasing overall health cost and utilization, and overall increased mortality. The Kaplan-Meier curve that we see here on the left of the screen compares three subgroups here. Those with COPD who have no exacerbation, those with 1 to 2 exacerbations per year, and those with 3 or more exacerbations per year. These were all normalized for lung function and other potential factors. And there's an appreciable worsening in mortality the more exacerbations patients tend to suffer. And it's not only just the number of exacerbations, the severity also matters too. Again, a similar Kaplan-Meier curve from the same Soler Catalunya study showing the difference between no exacerbations and number one on top, going down to those who get admitted and readmitted to the hospital with worsening survival on each one of these. So obviously the name of the game in COPD, as we all know, is stop exacerbations and ideally prevent them. So the strategies to really manage these and kind of break this cycle, this is my just overall construct here. Step one is really confirming the diagnosis. Step two will be characterizing the patient's COPD both chronically and in the acute exacerbation phase. Three is really finding out what is that exacerbating factor, what pushed them over the edge, and is it potentially something modifiable. Four is going through your toolbox, figuring out what the pharmacotherapy and potential interventions are in the armamentarium to actually break this cycle. I always say, in COPD, we unfortunately, the cardiologists always look great. When they go in and cath an acute MI, the patient's chest pain goes away. They said, you're the best doc in the world. Not the case for many pulmonary diseases, and especially COPD. It's the sum of a lot of small things. But equally, I think you can have just a strong impact. But it just takes a lot more effort and a lot more time and trial to really get to that point. So going to step one here, confirming the diagnosis. This is my own little pet peeve here, in that any patient who comes in with the nonspecific respiratory symptoms that fill our clinics of dyspnea or cough, if they've ever looked at a cigarette and they're over the age of 50, they get a chart diagnosis of COPD. The flip end is that we often get a lot of smokers who don't actually get the pulmonary function test or identify that their smoker's cough is actually COPD until late in the disease. So as paradoxical as it sounds, COPD is both over and underdiagnosed. The underdiagnosis, again, as we know from many of our respiratory diseases, by the time they actually get enough damage and bubble up to being seen in our clinics or by a primary care doctor, a lot of damage is already done. But you can make the argument of, why does this matter? Why do we really identify? Well, when it comes to COPD, if you look at patients from the time of diagnosis, those diagnosed later in the disease course are going to have worse quality of life, higher mortality from that time of diagnosis, as well as more exacerbations. So I know I'm preaching to the choir with this audience here, but early diagnosis is quite important. Now, what's interesting is that our failure to really identify patients early, there's actually gender bias that's been elucidated. This was a really elegantly simple study by Chapman from, I think, mid-2000s, where Dr. Chapman offered STEMs to various clinicians. And he either offered just history and physical plus spirometry, and history, physical, spirometry, and the fact that a patient got an oral course of corticosteroids with clinical improvement. And the only variable change in the study was whether the patient was male or female. And you can tell by the table demonstrated here that there's almost a 15 to 20% difference in responders, whether or not they identified it as COPD just based upon the gender that was identified. So, the Frank Netter, pink puffer, blue bloater that we all learned in medical school for the normal COPD patient, that's not right. The COPD Foundation always throws up Christy Turlington here as someone who started smoking early in her modeling career and has kind of COPD just as much as any of the men. In fact, if you look at population prevalence in the United States, there's actually more women with COPD than men. As far as the overdiagnosis aspect, again, this is rife in every healthcare system. The BOLD study, the burden of obstructive lung disease, did a cross-sectional analysis of 16,000 or so participants in the United States. This is actually multi-state, but the U.S. cohort identified 919 patients with a diagnosis, a chart diagnosis of COPD. When they actually sat down and did spirometry on these patients, right, they found 569 or 61.9% didn't have obstruction. They're missing the O in COPD. That's profound because about almost 50% of these patients were prescribed a respiratory medication. So not just the high cost that we all know healthcare makes our patients pay for respiratory medications, but the fact that often the real driver of their shortness of breath and dyspnea is often being missed. So these patients they're suffering from this label on their head of COPD, where they get the reflexive treatment of an inhaler, a handshake, maybe some corticosteroids. So the alternative diagnoses, again, for this audience, this is very common. The ones I see really bubble a lot here, a lot of heart failure coming into the COPD clinic, a lot of aspiration that gets mislabeled because they get a little wheeze when they actually do aspirate gastric contents, and obesity hypoventilation syndrome. Those are the big three that I quite commonly see in clinic. Again, as far as just patients in the hospital, Spiro did another study, somewhat published in the last couple of years, and found that probably a third of patients who end up getting hospitalized, right, sick enough that they're hospitalized, they catching a label for COPD exacerbation, a third of those probably actually don't have COPD if spirometry is done. Looking at this cohort, there's actually a literature surrounding it, and inadequate diagnosis. This is defined as someone with a chart diagnosis of COPD without confirmatory testing, including spirometry. They found the most common group of people who have this are obese patients, probably with the obesity hypoventilation. Women tend to be underdiagnosed, as I mentioned before, and those with other comorbidities, right? Again, the mislabeling from you looked at a cigarette once and you're old and out of breath, it's probably COPD biases. So moving into step 2, right? Even when dealing acutely with an exacerbation, it behooves you to identify the phenotype and endotype of the patient's chronic disease to figure out how to best take care of them. So for those of you not familiar with this terminology, endotyping is a condition defined by a distinct pathobiological mechanism, such as emphysema, right, or Th2 inflammation in the airway, whereas the phenotype is more the outward observable characteristics of an individual resulting from that interaction with the endotype, right? So obviously this is where the direction a lot of pulmonary diseases are going, and making an emphasis to really identify the endotype as best as you can by looking at both not just the clinical aspects of the phenotype, but looking at biomarkers, lab values, radiographic evidence to really figure out best what's actually happening inside the lung. Now, I loved the statement here out of Mir Vitles. I'm probably butchering that word, his name. But it was, he stated that there's no consensus on the number and definition of the different COPD phenotypes. It's being anywhere from 2 to 328 million, the estimated number of patients worldwide. So, yep, we can have the blue blooder pink puffer, or we could have every patient's a snowflake. And the reality is both of those just aren't clinically beneficial. What we really care about is targets, clinically meaningful phenotypes, right? Not just esoteric labels that we place on patients. Where parts of their disease that we can have specific therapy and have our management differ because of that label we give them. So each one of our main airway diseases that we deal with is moving this direction, right? Bronchiectasis is really moving to better subtyping it instead of clumping it all together, right? Asthma, we all know, really has a big push on the variable endotypes associated, and COPD is no different, right? But my big challenge is that there's a heck of a lot of overlap between a lot of these, both in the clinical manifestations, the actual disease, and there's often patients have concurrent diseases. Asthma, COPD overlap. Bronchiectasis is quite common with COPD, especially those with alpha-1 antitrypsin deficiency. So my approach is actually, I just look at airway disease as all airway disease, and I try and think down all three axes when I'm trying to phenotype a patient, right? So I look in kind of the airway inflammation, kind of identifying that inflammatory endotype that's going on in the patient, right? Eosinophils, fibrinogen levels are quite helpful in identifying patients at risk for exacerbation. but also not just figuring out the inflammation or lack of inflammation potentially, that we think is going on in individual patients' lungs. But what are the drivers of those inflammation, right? Making sure not we're missing ABPA, aspirin sensitivity, again, other easily modifiable drivers that could be masquerading and causing their airway disease. The kind of second axis that I really think about is kind of the bronchiectasis, chronic bronchitis type axis, right? The airway clearance, mucus hypersecretion group here. I'm thinking about our mucolytics are an option for our patient. Is there chronic infection that we should be testing for and potentially treating? And most importantly, what are we doing about airway clearance? I've changed my own practice. Instead of asking patients, do you produce mucus? I now ask them, have you failed efforts to try and get more mucus out? You can't feel the mucus in there, right? Often they don't feel the plugs up. And we've all heard this taking care of our patients. It's, oh gosh, I actually coughed up a bunch and I felt better after I stopped coughing and got it out, right? So I think we're, at least personally, I've been asking the wrong question for too long. So again, chronic bronchitis and bronchiectasis, there's a big overlap with COPD in general. Vespo et al. Showed that when you look at COPD exacerbation, chronic bronchitis patients, those with mucus hypersecretion are at a higher risk of having severe COPD exacerbations. The COPD gene cohort found more exacerbations in the chronic bronchitis subjects, especially those with severe exacerbations. Now, there are some trials, RCTs, without this as a primary outcome, which have not shown this to be true, but it seems like the signal is more promoting that chronic bronchitis is a risk factor for exacerbation. Now, what can we do about it? Again, the label's powerful because there's a lot of myriad things that we can do to actually help decrease mucus secretion and help improve clearance and function, right? There's, I came across this interesting study by Pauner where they actually protocolized their approach for airway clearance, including evaluating patient-specific needs, starting a nebulizer if appropriate, starting nebulized mucolytics, assessing for macrolide therapy, and initiating high-flow chest wall oscillation. And again, this is an unblinded study that was prospective, but it did show a significant drop in the exacerbation rate, the severe exacerbation rate in the cohort, as well as the group who got the intervention also did have a significantly improved symptom scoring subjectively, right? There's not a large body of data on this, to be honest, not robust randomized controlled trials. But I would say, anecdotally, I find this to be something very worthwhile and often where I get a lot of juice for my squeeze in taking care of patients. We typically start again with bronchodilator therapy coupled with flutter valve devices, but have a low threshold for escalating to high flow chest wall oscillation in the inappropriately selected patients, and again find significant help for patients, not only when they're in their chronic phase, but especially for the frequent exacerbators. One of the things I like to do is try and really arm them for managing their exacerbations at home to keep them moderate so they don't end up in the hospital or emergency room. And there's even less data on high-frequency chest wall oscillation therapies. There's really one prospective study, obviously unblinded, which did show a drop in subsequent hospitalizations in patients, but again comes with the intrinsic biases of being unblinded and relatively small in cohort. That being said, again, I do find this device potentially helpful for patients in the context of their disease, coupled with appropriate other therapy. And really, again, the goal should be to prove that there's not mucus in there, not just saying they cough just fine and they don't have a significant burden. So the third axis that I really focus on here is the respiratory mechanics, because this is the kind of classic, more emphysematous subtype of the phenotyping. Why does this matter? It's really about identifying the amount of static hyperinflation, especially in the age of endobronchial valves and potential for lung volume reduction interventions. Thinking about CO2 retention patients for positive pressure interventions such as nocturnal BiPAP or non-invasive. And also just seeing the overall burden on the respiratory mechanics, right? This is when I'm kind of contributing into obesity and diaphragmatic dysfunction and their overall function. And ultimately, what the visual construct I'm trying to kind of put together in my head here is something like these axes, right? Where that blue line would be a good example of the kind of pink puffer with more of kind of a respiratory mechanics burden, as much more so than the inflammation or the airway clearance. Whereas you might have someone with a little bit of each, and just kind of, again, figuring out the individual's phenotype of the patient. Now, once we kind of phenotype the COPD, the important next step is to blame the other specialists. So it's finding the other causes of dyspnea that these patients get. Unfortunately, they're allowed to have multiple diseases. And as we know in COPD, there's multiple diseases that, even when you control for other risk factors, such as smoking, they're still more prevalent in COPD than the general population. The big ones are heart failure and coronary artery disease, pulmonary vascular disease, arrhythmias, pulmonary fibrosis, like Dr. Oldham mentioned last go around in this talk, hypertension, osteoporosis, aspiration, anxiety, depression, lung cancer, bronchiectasis. There are many other reasons patients should be short of breath. And it's often the ones with multiple of these that bubble up to seeing us pulmonologists in clinic. So again, the take home is to try and find these labels, not just to put a label on someone, but to figure out where those actionable items. This is just a list of some of the phenotypes that I have in my head in listing them out, somewhere between the 2 and 328 million. But as you can see, the list, you can keep making other subgroups here that can potentially identify the care. So moving to step 3, we finally get into focusing on the exacerbation itself. And there's many causes of exacerbation, as we know. Most commonly, or quite often, they're triggered by viral infections, and when compared to bacterial or other etiologies, these exacerbations tend to last longer. Tracheal bronchitis, tracheitis make up to about 50 to 60% of the patients with a common community-acquired organisms that we're all used to. But especially in those with really severe disease, airway dysfunction, such as bronchiectasis, and those with very frequent exacerbations and interactions with the inpatient setting, I have a low threshold for actually instituting anti-pseudomonal coverage. There was just a paper, I think, in Blue Journal this week that demonstrated that, again, in these high-risk patients, frequent exacerbators who touch the hospital, that empiric upfront coverage with Pseudomonas cuts down on readmissions. So there's evidence to kind of do what the ID docs hate to hear from us, is starting things like levofloxacin for exacerbations. But for those really high-risk people, I think it's not unreasonable. Short-term exposure to PM 2.5 increases COPD admissions as well, especially us in California with the wildfire exposures. This is another thing that is tough to ignore. The data shows that this is more impactful for moderate exacerbations than mild. It doesn't have a huge dent, but probably some on the inpatient settings during the wildfires. And then another big one that I'm always looking for is aspiration and the effects of dysphagia, especially in people when they get more than 2 to 3 exacerbations per year. I really start looking on these, and we have a pretty tight relationship with our ENT physicians and speech and swallow specialists to evaluate for this, with a quite low threshold to send them over. So just as we phenotype the type of COPD, there's effort to phenotype the exacerbation. The image over here, this is a heat map for 3 subgroups of COPD exacerbations. Group 1 is your classic severe COPD with a lot of obstruction. Right. This group 2 here was moderate obstruction with more mild airflow obstruction with more of a classic emphysema group. You can see, just comparing 1 versus 2 in respiratory symptoms and quality of life, much worse in group 1 as you expect, worse lung function, worse x-ray, everything you'd expect. What's interesting, though, is the group 3, where you have the mild to moderate airflow obstruction, but comorbidities like heart failure, COPD, as the exacerbating cause. You're getting severity just almost as bad as the severe exacerbation patients. Obviously with differences in lung density, but symptom scoring is almost as bad, right? Nutritional status is worse. 6-minute walk is worse in these patients. So again, looking for those reasons to blame the cardiologist is always worthwhile. There is, again, an inflammatory move here as well. This is a more elegant view of phenotyping the endotype by a paper by Garcia, where they clump it into Th2 high, Th1 high, kind of pro-inflammatory, which is more neutrophilic driven, and posse-immune etiologies of COPD exacerbations. But the really important thing to preach here, I tell all our house staff that COPD exacerbation is not a thing. It is something that takes advantage of a patient with low reserve. So I harp that because there's too much reflexive treatment for COPD exacerbation, especially when patients get admitted to the hospital. You get steroids, you get 3-4 days in the hospital, O2 support and nebulizers, and hopefully they're better at the end. If not, we'll send them home and tell them it's going to take a long time to get better. If you don't go hunting for that exacerbating cause, what pushed them over the edge, they're not going to get better quickly, and they're more likely to kind of come right back with that same unintervened upon cause. So step forward as we move into our toolbox here. What do we have to actually change the course of these COPD exacerbations? So corticosteroids are usually obviously our first line of defense in treating these acute exacerbations. On the inpatient end, with severe exacerbations, they've been shown to cut down length of stay, in-hospital O2 requirement, FEV1, and dyspnea at discharge. And importantly, they decrease the risk of relapse and treatment failure. So it's pretty commonplace. I don't think anyone argues that corticosteroids have a role in the treatment of inpatient COPD. What is interesting is that oral administration is just as effective in the trials here. So there's no reason to necessarily push towards Solu-Medrol, Decadron, etc. As long as you trust their gut function. Shorter duration is just as long as good, as good as longer, rather. So a recent study showed 10 to 14 days really found no difference, and then actually more side effects from the corticosteroids the longer it went along, as we expect. So, half a mg per kg for 5 days makes a lot of sense. The one pet peeve of mine, to get on my soapbox a bit, is that for some reason with COPD, we tend not to weight base our prednisone dosing. We do this for any other autoimmune disease, right? But my 5'0" mother-in-law needs a much different dose than my 6'5", 200+ pound father-in-law, right? I think really thinking about that, especially on the low end, thinking about dosing appropriately makes the most sense. So again, for exacerbations, we often forget the easiest answers, right? It's bronchodilators and inhaled corticosteroids, right? That's the mainstay of our therapy as well. But really making sure it's the right drug, it's the right patient, and the right delivery device is really important, especially when they've already had an exacerbation, right? So if these drugs are administered well, they can cut down the exacerbation rates by upwards of dropping the relative risk by 0.2. And inhaled corticosteroids are not for all. We'll talk about that in a little bit. But the device is something that's very important, right? The first screen really should see if they have the cognitive function, right? Are they able to actually do the quite complicated task of using their inhalers for some of them, right? I'm looking at the HandiHaler as an example, right? If not, if they have some early dementia or other kind of cognitive impairment, low threshold to get them over to nebulized therapy. The second thought is that they just have the manual dexterity to actually do this, right? The advair discus, for an example, right? Quite, can be difficult for our patients who have bad osteoarthritis or just don't have the manual dexterity. Again, if we think that's an issue, low threshold to get them nebulizer, especially if they've already had an exacerbation. What we've been using more recently in our own clinic is measuring the peak inspiratory flow, peak inspiratory force, to see if they actually can generate enough force to get adequate drug delivery. In the pre-COVID days, we did this reflexively in almost every patient who came through our COPD clinic, and it was really helpful to guide therapy. Again, especially our dry powder inhalers are quite force dependent on the drug delivery. And, often our sickest patients are the ones who can't generate that inspiratory force. So again, you should think about other inhalers that don't need such a significant inspiratory force, such as soft mist inhalers, as well as again, switching to nebulized therapies. Right, the risk factors for insufficient drug delivery: age, cognitive and manual impairment, as we mentioned, low inspiratory pressures, and also we're thinking about looking at the patient's airway, right? If they have Mallampati 4, you're just less likely to get adequate drug delivery. And again, thinking about nebulized therapy might be the best answer. This is just a nice table here that just kind of goes over what I said here briefly a second ago. Again, there's more recent literature about figuring out who's right for ICS. There's one thing I know about giving talks on COPD. There's no better way to lose the audience than to start talking about head-to-head trials between LAMA-LABA, LAMA plus LABA versus ICS plus LABA, right? That bores me too. But if you'll indulge me for a second, the ICS is something important, right? This was a really nice, elegant study. This is actually pooled data from AstraZeneca from 3 of those trials where they compared LABA alone versus ICS plus LABA, budesonide and formoterol in this case. And they reorganized from looking at the patients, again, for the y-axis being annual exacerbation rate, and organized it just based upon the eosinophil count, right? And they found that kind of in this threshold of about 100 or so, right, or less of eosinophils, you really don't see any change in the exacerbation rate. It's nothing statistical. But the higher your eosinophil count, the more you missed having that inhaled corticosteroid on board as far as your exacerbation rate. As you can see, the separation from the blue and pink lines here. So this has really shown that eosinophils may actually be a reasonable biomarker, again, for identifying that endotype of the inflammation actually happening within the airway. So the GOLD guidelines were actually influenced by this data and other studies such as Sunset and some other clinical trials. And this is the most recent table here showing when to think about inhaled corticosteroids. So if someone's had hospitalizations, again, lower your bar. Really, they got to break the cycle here. It's likely to be inflammatory just based upon that. 2 or more exacerbations per year, you're getting to thinking about it's helpful. But again, more than 300 eosinophils is a pretty strong indication. Now, one challenge I always have, especially when we have longitudinal data over a long period of time, is what lab value do you look at? It's hard to tell when they're on prednisone, right? That'll squash their peripheral eosinophils down quite low. So the way I look at it is more the peak. Are they able to generate high eosinophils? And so that's, again, just the surrogate I end up using for it. And the important things not to forget here, though, is if they have concomitant true asthma, you should really be being less elegant, not looking at the eosinophils as much, and they probably should be on inhaled corticosteroid. The flip end is if they start getting pneumonias as their cause of exacerbation, those patients, again, probably not a great mix for inhaled corticosteroid. There is some evidence that there's difference between the corticosteroids, again, not with prospective studies, with potentially budesonide being a little less likely to cause pneumonia, so sometimes I'll swap to budesonide if I'm concerned about that. But again, pneumonias can often masquerade as exacerbations, and unfortunately the cycle is you get more and more inhaled corticosteroids and increasing your risk for them. Antibiotics are another interesting intervention here that's kind of come up. Obviously, in the acute phase here, we've shown that in both in severe and in very severe exacerbations, mortality and deaths and need for additional antibiotics seems to be decreased by giving antibiotics to all comers, right? So hence the recommendation that we often give antibiotics regardless of if there's a low bar infiltrate per se. Moderate exacerbations, the data is less robust. Now, there's a lot of house staff I see around, at least at Davis, have a predilection for using azithromycin as part of the concoction. Now, there's no magic to this. There's been multiple studies comparing Bactrim, fluoroquinolones, doxy, other macrolides. None of them superior, and there's actually been head-to-head studies against some of these, and none of them seem to be leading the cause here. So again, when you maximize out your inhaled bronchodilators, inhaled corticosteroids, that's when we get to the next phase. And this is what often gets forgotten, especially in the inpatient setting, is thinking about that next step, right, of moving on. Whenever someone's admitted to the hospital, I think you failed outpatient therapy. You need to make the step up. And this is often where we kind of miss the boat. Roflumilast is a great phosphodiesterase 4 inhibitor that decreases airway inflammation through cyclic AMP degradation pathway. No bronchodilator effects out of it. The big adverse events is usually diarrhea, nausea, weight loss. These tend to be happening in the first week, so I really prime patients a lot for, hey, buckle up. This is you're gonna have a bad first week, but week 2 is hopefully be a lot better. The strongest post-hoc data that shows for these patients is really those with an FEV1 less than 50% and a chronic bronchitis phenotype. Really the ones who respond best to this group here. It shows in trials that, again, the exacerbation rate, the relative risk is about 0.8, right? Now, that's a similar relative risk that's popped out in the various randomized trials in chronic macrolides. It's about 0.8 or so. There's been multiple trials with macrolides, confusingly using different doses, anywhere from 250 milligrams daily to 3 times a week to 500 milligrams 3 times a week. Erythromycin's also been studied before. All have a similar, again, effect on exacerbations. There was a trial somewhat recently who actually showed starting this on inpatient actually cut down on readmissions as well. So again, not missing that opportunity to kind of escalate care is worthwhile. The post-hoc analysis suggests less of an effect in active smokers. It almost goes to relative risk of 1.0, so no benefit. So really trying to avoid this in active smokers. And then again, the risk factors we always worried about: prolongation of QTC, impaired hearing, which tends to be reversible, and bacterial resistance. The data on all these trials is 1 year long. Nobody really knows long term. Is the resistance going to be worse? The hearing can be worse. I've got a good number of patients in my stable. I'm interested in the group if you guys have any problems, but I've got many people on it for more than 1 year and haven't run into too many problems, at least that I'm aware of. Vitamin D deficiency. I know I'm stepping in it a little bit by mentioning vitamin D always with any disease. The real challenge here is it a biomarker, or is it a treatable trait, or are you just identifying sick people, right? People who aren't going out in the sunshine because they're so dyspneic and sick and they're just not getting vitamin D. I bring this up because this actually worked its way into the GOLD guidelines. They recommended considering treatment in people who are frequent exacerbators with levels less than 25 nanomoles per liter. And that's really based upon a meta-analysis, which I'm showing the results that it looks like there's a trend that's just inching the favoring toward intervention. Again, in my own clinical practice here, it's kind of there's a little bias by indication. A lot of the patients who are frequent exacerbators I'm thinking about this are ones getting a lot of prednisone, who I'm inclined to push toward vitamin D and calcium supplementation because of that. But it's a relatively low risk intervention here, and it's something I more prescribe it for the latter. Beta blockers are another really interesting narrative here. We know that in healthy subjects, they'll actually beta blockers will mildly decrease the FEV1. Right? Not great. We always worry about that in our severe patients. But interestingly enough, retrospective data showed that there's a benefit for beta blockers. Right, with 15 retrospective studies showing that they're actually associated with about a 38% risk of acute exacerbation. Not to mention, the other flip of that is that beta blockers, they're underutilized when there's a strong indication for them. So Lipwolf and Vanderwood did studies that showed post-MI, only about 20 to 60% of the time COPD patients with MIs were actually given beta blockers, with strong, overwhelming indications, obviously, to be on that medication. So they're inappropriately being missed in some patients. But the question here is there actually an intervenable medication that can actually change the course of COPD exacerbation? Again, there's some basic science that it impairs goblet number and function and mucus amount, inhibits neutrophil chemostasis, as well as reducing systemic inflammation. So the biology is there. So it actually kicked its way up to a large RCT, metoprolol for the acute prevention of acute exacerbation. Unfortunately, this study was stopped early due to lack of efficacy and maybe even some harm for severe exacerbations, where you see there's a higher rate of severe and very severe exacerbations in the intervention metoprolol arm. So unfortunately, the study was stopped prematurely. Right now, there's no role of using a beta blocker for the sole indication of exacerbation, but I think as pulmonary clinicians, all of us need to be mindful of really reminding the primary care and cardiologists, don't stop on our behalf, right? Use a cardioselective beta blocker if you can, if you're really worried about it, but don't stop the beta blocker just because they've got a history of COPD. The other one, again, we forget a lot, is influenza vaccine. This is a 1B recommendation from ATS to get your flu vaccine for the goal of cutting down exacerbations. Yet only about 50% of our Medicare patients actually got their flu vaccine. It really seems to cut down moderate exacerbations and mortality. There's recently a study done, I believe it's out of Chicago, looking at retrospectively all their patients who had COPD exacerbations and whether or not they were vaccinated. They found that influenza-positive patients experienced higher crude mortality and critical illness. And there's a 38% reduction in influenza-related hospitalizations when patients were vaccinated. No big surprises here, but again, just don't forget the simple things of really pushing harder on the exacerbations for those who miss it. Alpha-1 antitrypsin deficiency, right? Again, looking for those phenotypes and targets here. The data supporting augmentation therapy for our ZZs, it's there, but it's not robust, right? There's observational studies demonstrating that exacerbation frequency decreases. But again, Exactal, which is a larger randomized trial here, perspective, didn't really show an impact on the frequency. And it makes sense to some degree when you think about the anti-inflammatory properties of the protein, that there's probably a greater effect on the severity than the frequency. So again, I work in our alpha clinic as well, and I noticed our patients are, again, most likely anecdotally, but some of them say they swear that they get exacerbations when they come off the augmentation for whatever reason for a period of time. Moving into kind of non-medical therapies. So non-invasive is getting more and more attention in the COPD world, both nocturnal non-invasive therapy as well as ambulatory non-invasive, things like the Life 2000 device. That being said, there's some great guidelines that just got published by ATS guiding long-term non-invasive ventilation in COPD patients. I'll spare you most of them here, but one of them actually recommended against starting this during acute exacerbations, especially those requiring the hospitalization. Now, I disagree with this a little bit, right? For our patients, we clearly see chronic respiratory acidosis and a bicarb that's never been below 30 for the last couple of years. I'm still inclined to go ahead and say, yeah, that patient's probably going to benefit from non-invasive as an outpatient, right? And I'm not necessarily going to wait for the 2 to 4 weeks for intervention. But for all comers, the recommendation for now is actually that it's not beneficial just because they came out of the hospital for an exacerbation to start non-invasive. Those CO2 retainers are really the ones I kind of think about. So closing out to kind of getting those kind of the grab box, kind of the end of our line here in the toolbox here. One of the ones I really try and focus on is the depression anxiety. It is incredibly prevalent in this population, upwards of 4 to 5 times higher than the general population, depending on how it's measured and which population it's being studied in. Now, this is the death spiral of the COPD patient. They get more and more breathless, leads to anxiety and panic, avoidance of doing the things that take care of them, right? Both for their COPD and just their general well-being. They get deconditioned, they get depressed. It leads to all worse breathlessness, right? This is how they end up dying. My view is doing all those other things that we're doing before to get a foothold, to just push back on this so we can kind of reverse this cycle, improve the breathlessness, hopefully improve the mood by getting a little more activity and working with pulmonary rehab, getting back on those therapies and just kind of start climbing back up that hill a little bit that they've been slipping down. Again, I defer, my internal medicine board examination is got more dust on it than it should. So I defer the SSRIs and everything to the primary care docs. But I just find being a cheerleader for these patients and telling them this is a reversible disease, right? GOLD and a lot of the guidelines are really using that term. It's reversible, to just kind of get away from the defeatism that a lot of these patients hear from their providers, that COPD just doesn't get better and you're just kind of hosed and good luck, it's probably going to get worse over time. Pulmonary rehab, this is our phenomenal team here. You can't run a COPD clinic without a phenomenal COPD pulmonary rehab team. The data shows through Cochrane reviews here, reduction in readmissions, overall exacerbations, improved quality of life functional status, and a trend toward improved mortality as well. So I always tell patients this is the best tool in my toolbox, right? It's, again, I know this audience, I know you all know how impactful this is here, and we have to thank our pulmonary rehab teams every time we see them. There was a recent study that just got published looking to see, does it make sense to start it really quickly? There's, differing studies prior to this here, but unfortunately this one didn't really come to the statistical significance of showing a difference between starting pulmonary rehab early versus when the patient got more stable. That being said, this is the Kaplan-Meier curve, and this is just a cumulative incidence curve, and you're definitely seeing separation. There's a trend toward improved outcomes. So, the earliest you can get them in there logistically is kind of my personal goal. Now, again, getting some things that we just do in our clinic specifically. The data really hasn't shown the benefit as much as much as in asthma, but I'm a big proponent of personalized exacerbation plans. I've got young kids, and I know everyone gets sick at Friday at 5 p.m. when the clinic closes. So especially for our severe exacerbators, we fill out these personalized exacerbation plans, a bunch of if-then statements, not just saying what I expect you to be on a day-to-day basis and reiterating why they're important. What do you do for those just bad days, those mild flares, everything from airway clearance to bronchodilators to, a lot of my patients, I'll give prednisone and antibiotics to have on hand. As long as I know that it's truly COPD and that they have enough understanding and wherewithal to identify that and identify what would be different and what would get their attention. I go ahead and give them those antibiotics. And again, my goal is to get them through that weekend. I make sure they're very clear that this exacerbation plan is not a surrogate for communication with our team. But again, with multiple providers, RTs, nurses in our clinic, this is also a great tool to have in the EMR, so the whole team knows kind of what my thoughts are if they get an exacerbation. We are rolling out a remote patient monitoring program here. We've been doing with some kind of Protean devices right now, but we'll be using Propeller and some other ones here soon. And this is the future. I think the future and hopefully the present for many of you. Really being able to have that really tight eye. What we're finding in our clinic, it's not just the data that we get out of it. It's for those really high-risk patients, having that time where multiple clinicians are really focused on their care. You just pull up these small little things that cumulatively make a big difference. And it's worth that short period of time of really tight watching, monitoring. So kind of wrapping up here, the take-home points. Really move beyond thinking COPD or even exacerbations as a single disease, right? Really pushing, phenotyping the type of exacerbation, really to identifying the modifiable risk factors, right? Hospital admissions and any exacerbation for that matter it's failed prior therapy. Not to cast judgment, but my point is that it needs escalation of care, right? And there's lots of different options that we can do, right? It's a little bit of trial and error, as you know, but there's more and more opportunities that are coming our way. There's more biologics coming down the pipeline that'll probably be in the COPD realm pretty soon. And again, other therapies that we can do to really kind of change that course. And again, just have to thank my team here. I'm fortunate enough to work with some phenomenal respiratory therapists, some phenomenal colleagues in Mike Schivo and Sam Louie, the COPD Foundation, and our great patients who are quite inspiring for dealing with COPD every day. So I will open up for questions remotely here, and I thank you all for your attention, and feel free to reach out to me with any questions or concerns. Take care.